questions are regarding kidney and the kidney pathology. We started with mechanisms of glomerulonephritis, and then we came to nephrotic and nephritic, and afterwards we covered some renal tumors, main kidney tumors. So now, inshallah, we will be coming to the second part. So you know the nephron is a functional unit of the kidney, and it starts from glomerulus, it goes to tubules, proximal, and then leucophiliae, and then distal, and then it goes to collecting ducts. And then the third thing, which is in between where it is situated, is the interstitium. So after finishing, or at least at your level finishing glomeruli, we are coming down to the interstitium and tubules. First we will start with tubules. Among the tubules, we have some diseases which are statistically very important for you to know. For example, the most important is acute tubular necrosis, which is the 50% cause of acute renal failure. For acute renal shutdown, the most common cause is acute tubular necrosis. Then there are some other diseases which are involving the tubule life, which are called tubulointerstitial nephritis. Come here, come and sit between. Rida, please come here. ما في جواب.
كيف تخليني انا في النص يعني؟ مرة
Yeah, I'm not talking. I know that you are kind of restless, but these restless nights should not be preceded by, or should not be followed by a restless day. Okay? You try, come here, and inshallah, and then you will get some. So the tubular interstitial nephritis include pyelonephritis, could be acute, could be chronic, inflammation of the pelvis of the kidney. It's mainly part of that. Then there are some drugs. In pharmacology, maybe you have gone through a little bit of it, which can have some side effects on the tubules, can damage the tubules. Then the toxins, this forensic medicine or a little bit you will get an introduction, how the toxins can damage the kidney. A lot of so-called medicine, not truly herbal medicine, but some other which are made by some hukamas, or sometimes they have unknown toxins, unknown metals, and maybe they help a person a lot. Especially people use these kind of medicine and drugs for prolonging the sexual period and this and that, but ultimately the damage is happening to the kidneys because they are damaging these toxins, these drugs, these metals are ultimately damaging the tubules and interstitium, and ultimately sometimes leading to renal failure. So these are very common cause. And urate nephropathy, the urate crystals ultimately they can deposit not only in the joints, but they can also deposit in the kidney, leading to hypoglycemia, and then ultimately can lead to stone formation. So acute renal failure, because this I want to bring it here because the most common cause was acute tubular necrosis. But what is acute renal failure? There is a rapid deterioration of renal function in a very short period of time. When this deterioration of renal function is happening in a prolonged period, maybe years to develop, then it is chronic. But when it is in a very short period, maybe you can say days and weeks, then you will be thinking it is acute renal failure. Sudden inability to maintain normal fluid and electrolyte homeostasis. So suddenly, a person's ability to maintain its normal temperature, the normal hemostasis, normal solutes and normal toxins, everything, the homeostasis is lost. The electrolytes are not able to be adjusted by our kidney. That's something which is happening after acute renal failure. It is marked decrease in renal output. So we are, you can easily judge that if a person is going into acute renal failure, acute renal shutdown, by measuring or by having an idea of the urine output. There is no renal failure in which a person is having excessive renal output and he is going to fail. Rather, it usually presents with oliguria, and ultimately it leads to anuria. Okay, so anybody whose normal output is decreasing with a normal, amount of water intake, and still his urine is decreasing, there is oliguria in spite of normal intake of the water, this is one of the very alarming signs the person is going into renal
Will there also change the color of the urine?
Obviously, there will be there is more, sometimes more such sorts will be there. There will be more hypersaturation. It will be more darker. It will be more yellow. It will be more sometimes a little bit different change in color. A turbidity depending on what is the cause of acute renal failure. Maybe the glomerulus can lead to acute renal failure. For example, rapidly progressive glomerulitis can lead to this. There could be tubular causes like ATN, I will discuss today, and interstitial and vascular causes. Sometimes if there is a sudden blockage of the renal artery, renal artery stenosis, they can also lead to these things. So what are the causes? Acute tubular necrosis, as I discussed before, infarction and cortical necrosis. The cortex of the kidney can be necrosed. There is infarction because of blockage of the blood supply, because of any thrombus, or sometimes even the direct injury, it can lead to these necrosis. There are organic diseases of the renal vessels, as I told you. There could be atheroma, there could be sudden blockage, clot in that vessels. They can cause acute renal failure. If there is any severe form of glomerulitis, rapidly progressive, membranoproliferative, acute post-infectious, even if they become severe, ultimately they can lead to acute renal failure. If there is severe infection, well, that you will be astonished to know that in developing countries, even in Saudi Arabia, a lot of people, they don't have glomerulitis, they don't have acute tubular necrosis. Unfortunately, because of severe UTI or severe pyelonephritis, they developed acute renal failure. Why? Because it is causing so much infection and the ureter is causing hydronephrosis. The ureter are getting swollen and ultimately there is a back pressure, and this back pressure is causing the collecting liquor to get the pressure, and ultimately the kidneys cannot work properly, and the stasis of the solute occurs within the tubules, blockage of the normal circulation. So this can be very dangerous in developing countries where there are a lot of infections. So even severe infection is I have seen many cases of renal stones, especially the staghorn stones. They are leading to renal failure because of sudden blockage or blockage of the urine flow. There could be acute tubular interstitial nephritis, maybe because of drugs, maybe because of toxins, outflow obstruction, as I told you, post-renal, maybe because of stones, maybe because of fever. So all these things, they can similarly impairment of the blood flow, which is a pre-renal cause of renal failure by blockage of the renal artery stenosis, many things. So these are the things which can lead to acute renal failure in any form. So we will discuss the most important in this case, which is also a part of our tubular and interstitial topic. So acute tubular necrosis, it is the most common cause of acute renal failure, especially if the urine flow is less than 400 milliliter per day. Normally, it should be, what is the normal level of urine?
Between 800 and 1,500. 800.
Huh?
About 1 liter per day.
About 1200, okay, about 1 liter, minimum 1 liter, but sometimes it is 1,000 to 100, 500. Average, because it is variable in people to people and countries to countries, and the weather also, the exposure to the weather, how kind of weather is there. If people are living in a very cold weather, obviously there is a retention of water, like in Canada and in these countries. So it is variable, but it should be normally above 1,000, above 1 liter. Normally it could be 1,500, 1,800, it's okay, but 1,000 to 1,500. But if it is less than 400 ml per day, it is oliguria. It is one of the suspicion that it might have acute tubular necrosis or any other cause of renal failure. There is a restriction of what is the main cause in acute tubular necrosis. So acute means short time, tubular means tubules, and necrosis means there is something which is causing death of the cells, necrosis of the cells. And how that could be usually destruction of the renal tubular epithelium. So destruction is causing death of these tubular cells. There is 50%, as I told you, 50% of acute renal failure is because of acute tubular necrosis. There are two types of ATN. So ATN or acute tubular necrosis are mainly two types. This is also called mechanism of ATN. This can be called types of acute tubular necrosis. So number one is ischemic, ischemic reticular
Lack of
necrosis,
blood supply.
and the other one is nephrotoxic.
Just two types.
Poisons.
So ischemic, the word means
Ischemia.
Across the
Decreased
blood
blood
supply.
decreased blood
Decreased blood
supply.
supply.
Okay, and the nephrotoxic, something which is causing toxicity to the kidney. It could be metals, drugs, chemicals. It could be many things. Okay, poisons, carbon tetrachloride, some drugs like aminoglycosides. You know about aminoglycosides?
No.
One of the antibiotics.
Antibiotics, amphotericin B.
Also.
It is one of the antifungal contrast agents.
Contrast.
You know the use of contrast agents? We use contrast agents for different radiological procedures. If we want to see, for example, urography, you want to see the kidneys, the normal pathway, is it intact, is there any stone, is there any tumor?
They can
So
see the
after you check an X-ray for angiography also. So when then you will put the dye, which is called urographin, and then you again check the X-rays and see the flow of this dye. So these dyes sometimes can be very much nephrotoxic. Okay? It could be CT scan with contrast. So the contrast word means some injection of a chemical.
So you can see better.
Yes, it has been injected into the vascular system, and ultimately we will see the flow of that into that cavities, and by that we will try to get the idea. Okay, so a lot of graphies like urography, like angiography, like for example CT scan with contrast, MRI with contrast, all these things they use these dyes, also called contrast agents. So they are sometimes damaging to the kidney, causing tubular necrosis. So out of these two types, the first one is ischemia. Ischemia can be caused by shock or any hemolytic crisis. So we will go through this etiology and pathogenesis. For example, for the first one, which is ischemic in origin, usually the lesions which are caused by ischemia, we call them tubulorexics. Rexis means breakdown, fragmentation. Tubules be tubules. So whenever there is damage, injury, and ultimately the tubules get breakdown, get fragmented. So that is mainly what is happening. So the main cause here is if there is prolonged ischemia to the tubules. For example, in cases of shock, maybe post-operative shock, maybe septic shock, maybe post-traumatic shock, hypotensive shock, any form. If there is excessive hemorrhage, maybe accidents, maybe any abruption placenta, maybe because of postpartum hemorrhage, it can be any form. So all these forms, wherever there is excessive hemorrhage and blood loss, that can lead to generalized ischemia, and also the blood flow which is delivered to the kidney will also be less. So it can also lead to desiccation. Then others, for example, in cases of severe burns, because there is a lot of dehydration, so our skin is not available, so a lot of blood contains water. This water is lost through evaporation. So this leads to hypovolemia. Similarly, transfusion accidents, sometime you give negative to positive patients, so there is hemolysis, so all the RBCs are used, so they are not able to take oxygen to the tissues. So this can lead to ischemic crisis. Similarly, if there is heat stroke, if there is dehydration, if there is crushing injuries. Why crushing injuries? Not different. Crushing means, whenever there is so much injuries that the muscles are damaged. While road traffic accident, somebody is taken on the road like this, so a lot of muscles and these things are degraded, crushed. So in that case also we can have this. Why? Because they release a lot of proteins, myoglobulins and other things, which sometimes block the channels, block the blood supply. That can be one of the reasons. Damage pyramids, and that
What
can
is the heat stroke?
Heat stroke, you know about heat stroke sometimes, because alhamdulillah that we need not to have to work in outside in this sunny time, especially in the summer time. In June, July, people who are making these buildings, who are working in outside, they always give instructions. You have seen them, they are always covered with goggles, with caps, and a lot of cloth is on the back. Sometimes there is excessive heat which will cause because of sweating, a lot of dehydration happen, and they suddenly go into decreased water. Ultimately, because of this, they got hypovolemia and they got into shock. They got into syncope. So that is very dangerous condition. And a lot of people in summer season, when you will inshallah work in emergencies, you will see that in summer season, a lot of laborers, they are coming. So good.
He is a big boss here.
He is also leader. You are not changing. We have to change. You have decided whether you should not. We will not do it. I know that he is not alone. A lot of mashallah will be still coming now. Seeing less faces. Even the leader is not there. So now they will try to bring another email. The best thing is self correction. The most easy thing is to change yourself. We are here to change the system. But ultimately we don't want to change anything beside us and inside us. That's the problem. So a heat stroke will be in which there is excessive dehydration because of sweating, because of a lot of loss and no more excessive hydration. So they end up into syncope, and sometimes that syncope can lead to shock, hypovolemic shock, and that can be a reason for this. Now what is the mechanism of pathogenesis? That is excessive tubular damage because of any one of these reasons will affect especially the proximal tubules and the ascending loop of renal. Then there are four things which are happening. Number one, there is increased renin-angiotensin system. So with this increased activation of renin-angiotensin system, there is constriction ultimately. There is prostaglandin I2 which is decreased in nitric oxide. So ultimately we got vasoconstriction by this because they want to conserve the water. So because of this vasoconstriction, the GFR decreases. It can also directly causes the fluid flow or the filtrate. It got very slowed down in the kidneys. So once it goes slowed down, so if you see that if this Medina highway, if there somebody or some truck or some big vehicles are going, so after some times when they are going, a lot of vehicles, they were going at a fast pace, but because of that they got slow and slow, and ultimately there is a big line which happens. So this is a very common thing. You will see probably there is some accident, but when you pass by you came to know because of these two big vehicles. That's why you see in the morning they don't allow these because of these traffic blockage. Similarly, when the traffic flow gets slowed down, so this causes stasis of the filtrate. So the stasis of filtrate ultimately causes the hardening or the filtrate to become thick, very thick, and so much thick that it nearly stops, and it forms casts. It is called casts. These are called casts. What are casts? Actually, maybe in the next picture I will try to show you that what are these casts. These are excessive thick filtrate which got stuck because of decreased blood flow. It becomes very thick, more and more thick. A lot of water goes inside because of dehydration, so more water is absorbed. So rest is electrolytes and a lot of proteins and other things if they are also damaged. So like they got slowed down and ultimately they are not allowing the fluid to pass. So these casts are also causing obstruction of the remaining urine flow. Okay, so these casts are ultimately happening there. So there is tubular cast, there is tubular back leak. Sometime from here, the solutes or other secretion, they are leaking into the interstitium. Okay, so these both things are ultimately also decreasing GFR. This by increasing the intratubular pressure, and this by decreasing the tubular fluid flow. So both are decreased. Ultimately, this will cause the GFR to become decreased. And fourth thing, it directly damages or causing the interstitium to be inflamed. So this inflammation can also involve the tubules and the surrounding area, and ultimately can lead to some nephritis, some interstitial nephritis. So as a result of all this, decreased GFR, ultimately the direct glomerular effect will be there, and the glomerular filtrate will decrease. So, and this can also be ultimately leading to ischemia, and this ischemia is also directly affecting the glomerulus also. So this is kind of a vicious cycle which is going on after a person develops ischemic kind of acute tubular necrosis. Ultimately, the tubules which are there, they are totally damaged. There is fragmentation, and they are not able to be repaired. So if they are not able to be repaired, so they need the dialysis for this thing to be corrected. I have seen a lady who developed postpartum hemorrhage. Okay, okay. So postpartum hemorrhage after delivery, the whatever is less, she develops a lot of bleeding, and ultimately this leads to a lot of hypovolemia. Blood was lost, and and then she developed renal failure, acute tuberous necrosis. I was in attorneys, as an attorney working there at the time. I remember that we tried to wait for some time by giving normal solutes and fluids, but she was not improving. Ultimately, after second day, we tried for dialysis. Sometimes these patients, after 1 or 2 dialysis, they come back and their renal function is restored if the damage is not still very severe. But unfortunately, with 1, with 2, so she was looking all right. Because I was very junior, I was thinking that it doesn't seem to be so serious. Why they are giving so much instruction by these patients, for this patient particularly. But then after 3rd dialysis, when she was not improving, then I started to feel that, well, ultimately she was swelling, she was having a lot of nephrotoxicity, etc., uremia, and her the pleural effusion. And then I was seeing the patient was deteriorating a lot, and ultimately could not. I was shifted from at that time. I could not get the output of that particular patient. But this can be very, very dangerous, and the cause is the same, acute tuberculosis. Then the second type or the second mechanism is direct toxin injury, direct nephrotoxicity. So what could be things? It could be, as I told you, antibiotics, it could be chemotherapeutic agents, anti-cancer drugs, heavy metals, very commonly mercury. I told you, the people, when they make some medicine, this is very best medicine for this, especially for these kind of things. A lot of people, a lot of old people, they get prey to these people, we give them these kind of drugs so that you can have a long, because you got a new marriage, so you need to have extension of your time, so you should use these things. And a lot of these things are usually getting mercury and these lead. So they give something, but at worst of something, and ultimately the thing which is damaged are the kidneys. So radio contrast agents, multiple bee stings, scorpion bites, these are also sometimes very, very dangerous because they are directly nephrotoxic. Okay, I see one of our class fellows, he got a lot of bee stings, a lot of, maybe up to hundreds, 200. So his whole body was. So a part of swelling of the body, if the bees are very, they have this poison which they injected, it is very much toxic. It can directly damage the kidney, leading to renal failure. So these small things can be very much complicated at very long. And very astonishingly, even the scorpion bites, some species of scorpions, saratan, they are very dangerous and they can directly be nephrotoxic. Grossly, there is bilaterally enlarged and swollen kidneys due to edema. Obviously, because whenever there is a lot of blockage, so the fluid leaks out and there is edema of the interstitium. So they will be more swollen. They will be, the cut surface will shows a lot of bulges. You can see here. The bulges are seen here and there. They're dark red. Okay, these are areas which are there, and the interstitium or the pelvis is also getting disrupted, widened and pale cortex. So you can see that the cortex is widened and it is little pale. There is dark and congested medulla. The medulla becomes more darker as compared to cortex, and it is very congested, means it contains a lot of redness and darkness is because of this.
What's the meaning of flabby consistency?
Flabby means something which is soft and which is rubbery, or you can say rubbery or edematous look actually. Flabby is something edematous, swollen and edematous. On microscopic examination, there is necrosis of the proximal tubules. So you can see the tubules are very much necrosed, especially the tubular cells which are lining them. But very importantly, there is proteinaceous cast in the distal. So these are the distal convoluted tubules which contains a lot of protein casts. So protein stuck, it stops the blood flow, it stops the urine flow. So this is a very common finding in acute tubular necrosis in distal convoluted tubule. So there is interstitial edema from here. It is not shown, but from here, sometimes the fluid leak to the interstitium, causing edema of the interstitium. So the prognosis, it depends on underlying cause. Overall mortality is 50%. So the 50% cause of acute renal failure is ATM, and with ATM, 50% of the people are getting mortality. So it is such a damaging thing. such a worse thing which can happen. So post-traumatic, pre-operative medical causes, obstructive causes which can lead to acute necrosis. So after trauma, leading to hypovolemia and leading to acute necrosis, the mortality is 62%, and post-operative with ATN is 56, and other things are there.
So the traumatic is always the
There's
most-
always why? Because it is causing severe blood loss within short span of time. You know, if somebody got jugular vein damage, somebody got aorta damage, accidental. These major vessels, when they lead to a lot of loss of blood within very short time, and sometimes they cannot get proper help in a very in that particular place, and that lead to hypovolemia and shock, hypovolemic shock, and ultimately leading to necrosis. It is higher in old, very natural, because their immunity, their strength is less, and the patients who have multiple organ failure, they are more at risk of developing ATD because their rest of the body cannot help them to maintain to the norm. It is good for uncomplicated and younger patients. So those people who are young and who are uncomplicated, means no medicine, no previous diseases, no organ failure. So they are sometimes most
Good
likely
prognosis.
yes, with good prognosis in those people. It's not you can say good. It means good prognosis.
Yes, good prognosis.
Not as a whole the disease is good for them, but the prognosis is good. So clinical course. Initially, in the first 36 hours, which is called initiation phase. There is mild oliguria. There is azotemia. What is azotemia?
Increase in nitrogen.
Containing compounds in the blood
Nitrogen in the blood.
without phenolization.
Yes, increased blood urea nitrogen and urea.
Urea.
Okay, blood urea nitrogen and creatinine. Okay, both are there. So BUN is urea, blood urea nitrogen and creatinine. Both are raised. Then it is called azotemia. When it has sign and symptoms, it is called uremia. So initiation, there is this thing. Maybe no sign symptoms here. But in the maintenance phase, where the solute is going less from 50 to 400. So when it becomes less than 400, this is severe. Okay. So this phase it might be still above. But once it gets low than 400 or between 50 to 400, still it's in the maintenance phase and urine worsens. Azotemia is more. Dialysis. This is the point when you do dialysis and patient can get okay. But after this phase, when the urine output is less than 50 or it is anuria, usually even with dialysis patient don't come back. So this is if they maintain after this and they can recover. So there is hypokalemia which can happen. There is increased the urea and creatinine come to the normal. But those patients who don't recover and their urine output is less than 50
Renal
or
failure.
ultimately leads to renal failure and they are not coming back. And they are leading most of the time, 50% of the cases they are leading to mortality. So the other tubular interstitial nephritis, it could be because of infections, as I told you, pyelonephritis, for example. It could be toxins, heavy metals, chemicals, NSAIDs, metabolic, for example, urate, calcium, oxalate, salts. You will take them in the case, so I will not touch them. The physical, maybe because of obstruction, maybe radiation, immunological, maybe because of transplant rejection. So a lot of things, they can also not only damage the tubules, but they can also damage the interstitium of the kidneys. So a pyelonephritis. Well, this topic is related with the one which is you are getting in case related to renal stones. Pylo means
Pylo means what?
Renal interstitium.
it's called actually pelvis. Pylo is also what for word is for kidney.
Yes.
Okay. Pylo word is for pelvis and also for kidneys. Pyelonephritis. Nephro is also for kidney. So there is infection or inflammation of the pelvis with kidneys. So particularly it is caused by gram-negative. For example, E. coli, Proteus, and Enterobacter species. But it can more commonly by other gram-negatives, for example, Klebsiella, Streptococcus faecalis. These two are actually normal flora. But those patients who have decreased immunity, diabetic, they are more likely to become pathogenic. Okay? So these are the common gram-negatives. Where is the root of excess? See, kidneys are there. Usually the urine is sterile. The urine is sterile. You should not find any pus cells, another thing, or any microorganisms. But it can, once it gets pyelonephritis, you can get a lot of them. But from where they can come? There are two ways. There could be UTI, then it is called ascending infection. So one of the route is ascending infection. So the most common pathway is this actually, especially in the females, where the urethra is short. So from the perineal area, which have a a lot of normal flora, from there it can go into the bladder. Cystitis can go to a reflex which is called vesico-ureteral reflex. Normally the flow of urine is from ureter to bladder, but those people who have damaged this area, they have back pressure, which is called vesico-ureteral reflex. Vesico for bladder and ureter for ureter. So vesico-ureteral reflex. It causes backflow of the urine. So when it got backflow, the microorganisms which has already come here, they also go back.
Yes.
So ascending infection, it could be hematogenous. So from anywhere in the body, via blood, you know, the maximum blood flow from the body ultimately goes into the kidney. So from where they also delivered the microorganisms to the kidney. So it could be hematogenous or it could be ascending. It could be obstruction. It can lead to obstruction of the flow. For example, this can be that there is some congenital obstruction by valves, by ureteric blockage, by blockage of the urethra, stones, etc. A lot of things can cause. A lot of, if there is acquired obstruction because of blood clot, because of cystoscope, because of urinary catheter and it got infected. So a lot of way we can introduce the infection. If there is instrumentation, I already told you cystoscopy, then urinary catheterization, pubic catheterization. So any one of these instrumentation, which is an example of iatrogenic infection, they can lead to this pathology. Can you give me attendance also?
Attendance.
Everybody mark? Make sure that you are marking for somebody who is present, because today I will be not accepting anything. Like if somebody is not here, whether he is going outside or inside, I am not responsible. Okay, make sure no proxy, because in proxy I will mark 5, even the previous lecture absence. Don't try to make proxy. Ibrahim, okay, Ibrahim I know. But if he is coming back. So, instrumentation, vesico-ureteral reflex. If there is pregnancy, why pregnancy can cause more infections?
Because when the
Compress the
is
bladder.
more frequent urination, more frequent reflex.
Reflex, number 1. Number 2, because of the pressure of the uterus or the baby, it is also on the pelvic vein, so this causes blockage sometimes. Okay, then especially it causes pressure of the ureters. So there is blockage of the ureter or decreased flow in the ureter, causes back pressure. Similarly, in young ages, there is more chances. In old ages, there is more chances. In females, there is more because of short urethra. If there is
in young or old age? Young.
very young and very old.
Oh, okay, so not.
Very young means children. Again, because UTI is more common there. Again, with very old, the immunity is less.
Because of very young children UTI, is it because the poor hygiene?
Pure hygiene. Mainly it is poor hygiene and sometimes decreased immunity. You know, they got repeated infections, so already body is busy there tackling infection somewhere else, and they also got this. And mainly it is poor hygiene. So again, immunosuppression and immunodeficiency, any one of these things, they can cause pyelonephritis. In chronic pyelonephritis, what you see a lot of areas where there is pus formation. So there is abscesses in acute pyelonephritis, and in cases of chronic one, there is scar. You can see a lot of fibrosis, which is running here and there. So scars and fibrosis is in chronic, and abscesses will be seen in acute pyelonephritis. And particularly we see that the calluses, major and minor calluses.
What mean calluses?
The calluses are totally obliterated. They are not looking normal. As you see here, normally it should be, or this one, in this case, the calluses will be very much abnormal because of severe fibrosis, inflammation and damage. Okay? So microscopically, if there is acute pyelonephritis, we see a lot of edema, fibrosis, fibrin threads, a lot of hemorrhage, and a lot of neutrophils. So a lot of neutrophils are seen in the interstitium in this area. And in cases of chronic one, there is something which is called thyroidization of tubules.
Thyroid.
Why it is called thyroidization of tubules?
Look
Looks
like
like
thyroid.
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 Yes, actually it is not. The thyroid comes here.
Looks like.
But because
Resembles.
it resembles when the urine is stuck there, so it looks like as if these
Follicles?
are the follicles of the thyroid.
Contain
So that's
urine.
why it is called thyroidization of tubules. Now the drugs and toxins which can also cause interstitial nephritis, for example, penicillins, very commonly. Rifampicin. What is rifampicin?
Antibiotics
The
also.
drug that inhibit system B for
Anti-TB drugs which inhibit the, so both are right. Actually these are the rifampicin are very famous anti-tuberculous drugs, but they can also be given in a lot of chemotherapy. So this can also directly damage to the kidneys. Moreover, thiazide. That's why these drugs they always check sensitivity. If you are going to get any cephalosporin, sometime any penicillin, always they check the skin sensitivity.
Thiazide ده حبيب أنا.
Just to check the
Doctor, parasites
and
cause?
even
Parasites causes?
thiazides are themselves they are used for they are
Acute renal failure.
they are diuretics.
It's chronic use.
But in the chronic use they can also lead to liquid.
سوى؟
Okay. So 2 weeks later, there is fever, eosinophilia, what are the symptoms? Fever, rash, eosinophilia, and acute renal failure type of picture. That is commonly because of these kind of things. Now, this I particularly choose why, because this is something very common in society. Analgesics use over the counter, OTC, over the counter drugs. You go and you can get any one of these, especially the Brufona. That one is very much, NSAIDs, including the ibuprofen, have a lot of effect on the kidneys. A normal use is okay, but excessive use and NSAIDs, other NSAIDs, all analgesics, ultimately, especially the Tylenol, aspirin, and NSAIDs, they are markedly affecting the tubules and interstitium. Especially, they are occurring, they are damaging the papillas. Where are the papilla present?
Papilla.
Papilla.
Cortex.
Cortex. No. Medulla. Extend from the cortex to the medulla.
Huh?
ده حافظ والله ده حافظ مو فاهم. والله حافظ مو فاهم. بس
Okay.
اسكت.
So you know about this? What is this?
medulla.
Yes. It is this cortex. It is medulla. The tip of the medullas are these are the papillas. Okay. So tip of the medulla. Actually, typically, these drugs, these NSAIDs, analgesics, they make a covalent bond with these areas, and by making them, once they bind them, they causes release of a lot of free radicals, oxidative damage, and typically those free radicals are causing necrosis of the papilla. So these are the typical areas. You can see here how much papillary necrosis is going. So these are
How much
هتموت يعني.
how much is excessive use of
and pharmacology very thorough in the next because it was supposed to be in this block, but now because of shortage of this, we should be dosing. Chala, you will get the dosage calculation for different types of drugs, how much use and these things. To support you pure pharmacology.
once per week is
No, it's not per much.
Only
Even
cases
once,
can.
for regular use of maybe 2 weeks, 3 weeks, 4 weeks, no problem.
once per
But
week.
but it's also not only the duration, but the
amount.
but the amount or dose, which is more important. Okay. So with this, we will touch the main themes concerning the tubular interstitial nephritis, acute tubular necrosis. Now we come to the last topic for today, that is urinary bladder neoplasms. Regarding urinary bladder neoplasms, so you know that what is the normal epithelium lining?
Transitional.
Transitional epithelium. So what would be the most likely tumor?
Transitional tumor.
Transitional. Remember, what is the normal tissue? That becomes sometimes abnormal tissue, and then most chances to develop malignancies from there. So what is the normal? Most likely the normal tumor will be from there. For example, if it is GIT, what you will suspect? Most common tumor.
What's your mean?
Adenocarcinomas, yeah, because they contain glands.
Yes.
Okay. Similarly, if it is brain, most common tumor should be
Medulloblastoma.
It's common in children, medulloblastomas, from the cerebellum, from posterior fossa. But obviously there are glial cells, so there should be more chances that there should be gliomas or glioblastomas. Similarly, wherever the tumor, for example, if it is lung, again lung is having, the lining epithelium is pseudostratified columnar and it's have mucous glands, or chances are adenocarcinomas. So whatever is the normal tissue there, normal histology, it is more likely to develop a tumor from the same things. However, in some cases, there are some metaplasias. For example, the normal tissue of esophagus is normal lining is normal lining is
Stratified
squamous. So the normal tumor is squamous cell carcinoma. But sometimes there is metaplasia, conversion from squamous to columnar, and from columnar a tumor arises which is called adenocarcinoma, which is also Barrett's esophagus, which is leading to adenocarcinoma. So that is a different story. Here also remember the normal epithelium is
Transitional.
so the most likely tumor
Papilloma.
arising should be benign tumor of transition epithelium or the malignant tumor of transition epithelium.
Not say papilloma.
Papilloma is the most common benign tumor, but we will come to that. So bladder cancers account for approximately 7% of the cancer of the body. 3% of the cancer death in United States are caused by bladder tumors. The vast majority of bladder cancers are urothelial carcinomas, or also called transitional cell carcinomas. Men are involved more, and they believe that industrialized countries are those people who are at exposure of these chemicals, because the men are using cigarettes more, men are exposed in the industries to allylamines, so they are at more risk of developing these bladder cancers. 50 and 80 years is the most common age, old age, and painless hematuria. The most common presentation, a patient who presents with painless hematuria. Hematuria can also be a sign of
nephritic
nephritic syndrome, but that is usually also painful. Okay, but if a person is developing painless hematuria, so that's one of the signs which is very common in cases of bladder neoplasms. Okay, so the causes or risk or etiology: allylamines, aniline dyes, cigarettes, 10% times more risk of developing urinary bladder neoplasms. Schistosomias.
In the case.
Do you know what is schistosomiasis?
Yes.
Parasites.
Parasites.
They will take it in the case.
You have taken it in the case also?
زي الخرز
You will take or you have taken?
We take two kinds and we'll take one in the last case.
Schistosoma, hematobium, Mansoni. These schistosomiasis, they can also cause cystitis. And ultimately that cystitis can cause some of the cells to get atypical during repair, and then from that atypical cells bladder neoplasm can arise. So long-standing analgesics, same as analgesic nephropathy, drugs, most common NSAIDs, they can also have some effect in the formation of bladder neoplasm. Chemotherapy, especially the cyclophosphomides, which is a very common drugs for given in cases of breast cancers, in cases of leukemias. So that can also have a side effect that it can cause bladder neoplasm. And also people who have got radiotherapy, they can also have this. So what are the types of bladder neoplasms? It could be non-invasive and it could be invasive. Okay? It could be non-invasive and it could be invasive. The non-invasive, the most common tumor, benign tumor is papilloma. So papilloma will look like
Finger-like projection.
Finger-like projection, and it will be making a fungating growth, exophytic growth into the bladder, into the lumen of the bladder, and it will have no ATP at all and no invasion, obviously. Then the second one, which is in between this, still we don't find any invasion, but it has some ATPia, but not totally benign thing, but a little ATPia is still present. We call it as spun lump, papillary urothelial neoplasm of low malignant potential. Why they categorize? They need to categorize it, but because they found that this tumor was found to ultimately chances that it can lead to, it can grow further into low-grade urothelial neoplasias, and sometimes after some diagnosis, it can lead to an urothelial carcinoma, invasive ones. So they found that it has some malignant potential. So that's why it has to be dealt with surgery. Papilloma can be there for many years without any problem. So that's why they put a separate category. Then the low-grade urothelial carcinomas and high-grade urothelial carcinomas. Still, These are non-invasive. We don't find any invasion into the muscle layer. But once we see an invasion into the muscle layer of the urinary bladder, that is very invasive and that is very dangerous. Very bad prognosis. It is called urothelial carcinomas or transitional cell carcinomas.
TCC.
So this is the example of papilloma here. This is the low-grade urothelial carcinomas. You see that the layering increases. There is a little bit of atypia, but still they look a little similar. But in high-grade, the tumor cells, they lack cohesiveness. They are here and there. They are bigger and smaller. A lot of pleomorphism.
Like they are pre-cancerous.
Like you can see that they are
Before
progressing.
yes,
They
before
are progressing
carcinoma.
to that.
Yes.
And then they become invasive transitions of carcinomas. So morphology, invasive urothelial cancers, it is associated with papillary urothelial cancers. Usually they are making a big papilla or making a big. This is the bladder actually, which is urine bladder. Oh, it might be different. Why? Because the second thought which I came to mind now, but because it was written, it was there in the heading of the slide were taken from Google Images under the bladder cancers. It could be bladder, but the second possibility could be uterine cancer. Besides that, there is no possibility. So, but in any case, it might be prostate here. That's why I'm thinking that it's prostate and it is the bladder which is making a big growth into the lumen. It is totally blocked because of this. So usually, papillary urothelial cancers, usually by of high grade in nature, or sometimes carcinoma in situ may superficially. So superficially there is carcinoma in situ, but when we take a deep biopsy down, we say that it is invasive transitions and carcinomas. It invades the lamina propria. It invades the lamina propria from the epithelium, then the lamina propria, then the muscle layer, and then the cerebral artery. Then it invades the lamina propria or extend more deeply into the underlying muscles. Then the extent of invasion and the spread. So the invasion of the muscle and the spread staging at the time of initial diagnosis is the most important prognostic factor. So if it is not invasion, the prognosis is good. If there is invasion or spread, then the prognosis is very bad. And almost all infiltrating urothelial carcinomas are often of high grade. All invasive ones they found to be a lot of here. So here these are the urine sample of these transitional cell carcinoma where you find a lot of pleomorphism, some prominent.
They don't resemble the normal.
They don't resemble at all. They look
High
like
grade.
as squamous.
Yes.
So that's why they are very much high grade tumors. So with this, inshallah, we finish.
لا والله هاي